Dr. Madhu Uddaraju is the co-chairman of UVSMI Hospital, Bhimavaram. He also serves as a medical director in Sri Kiran Institute of Ophthalmology. Dr. Madhu Uddaraju has completed his post-graduation in Narayana College, Nellore, and also he did his fellowship in cornea from Aravind Eye Hospital, Madurai. Doctor has performed more than 1,500 corneal transplant in a short period of 4 years. Dr. Madhu has won several national and international awards.
Very good evening to all the friends from RIO Guwahati. So the talk today I'm going to cover broadly about microbial keratitis, and this will be more from the clinician's perspective, clinical perspective, with whatever limited experience we have in this field. There are no financial disclosures. The scope of this talk would go under the following headings. First of all, we'd look at the burden and causes of microbial keratitis. Then we'll see only with clinical examination or clinical diagnosis how we can diagnose between different causative organisms. Then we'll see about the role of microbiological evaluation and confocal microscopy. Then we'll touch upon the medical management and also learn about the landmark trials in microbial keratitis. Finally, we'll wrap off it with intrastromal injections, role of cross-linking in infectious keratitis, and surgical interventions. So if you see, there are nearly 2 million cases every year that suffer from microbial keratitis, that is trauma and infection, and nearly 5% of these cases end up becoming blind. And also the burden of microbial keratitis, for example, in countries like US itself, is 175 millions on the direct expenditure and an additional 70 million US dollar on Medicare every year. So if you can imagine, this is the expenditure that is in a developing or developed country, you can imagine what the burden will be, especially in our areas. So one important thing we need to see in microbial keratitis is the outcomes are poorer in fungal keratitis, which is associated with higher perforation rate, and surgical intervention also is higher in fungal keratitis when you compare it with other form of keratitis. And the treatment cost also sadly is 3 times more. So throughout our network hospitals, we see around 3 to 4 new cases of microbial keratitis every day. And one critical thing that we are facing in today's scenario is the emergence of antibiotic resistance. And this is the challenge that is being thrown upon us in the management of infectious keratitis. So if you see the causative organisms, a whole lot of organisms can cause corneal ulcers, starting from fungus. It could be bacterial, gram-positive, gram-negative, atypical mycobacteria, nocardia, which is also a filamentous bacteria, acanthamoeba, microsporidia, pythium, and sometimes a combination of 2 or 3 of these organisms, that is polymicrobial. And just for completion's sake, I will also touch upon the viral keratitis caused by HSV and HZV. So if you see, basically most of the ulcers we see fall into 2 major categories. Either it is bacterial or fungal. So if you are able to differentiate between bacterial or fungal clinically, I think half of your job is done. And the descriptions of these differentiations have been in the books, and 70% of the times they still hold good. The old teachings are still good in today's scenario. So if you see here in the first 2 pictures, these are typical cases of fungal keratitis, where you see serrated margins and the profile is raised over the ocular surface. And if you see in the 2 pictures in this side, it is well-defined margins and a flat profile. And here, if you go through the color also, The fungal keratitis will have more of an yellowish tinge towards the infiltrate, whereas in the bacterial keratitis, it is more like chalky white. So the main thing is whenever the margins are very discrete and the ulcer is raised and you have an yellowish tint, you have to suspect fungal keratitis. However big the ulcer may be, if the ulcer margins are well defined and you have a flat profile and it is chalky white, then you should suspect bacterial. Apart from this, you can also take a history and then differentiate between these two common organisms. So whenever there is a history of vegetative matter injury, or the profession of the patient is a farmer, or he has been using some steroids, all these things point out towards fungal keratitis. If it's more of an urban patient, contact lens user, minor non-vegetative trauma, foreign body followed by infiltrate, all these things point more towards bacterial keratitis. So this is how clinically you can differentiate between bacterial and fungal keratitis. So the major risk factors, what I practice in the Godavari Delta, where we have a huge population of farmers. So maybe whatever our experience, I will be telling from that point of view. If you see here, trauma with vegetative matter is the most common cause for fungal keratitis. And as I've told you, over-the-counter steroids. So if you see, most of these patients are farmers. They cannot come to hospital immediately for care. So what they do is they immediately approach the nearest medical shop. And unfortunately, in India, over-the-counter steroids are freely available. If at all they don't have an access to that also, probably they'll have some old steroid drops in the home given to them for some post-cataract surgery. Their wives or their own drops, or somebody in the family must have undergone, and these people continue using these drops for any problem in the eye. So because of this deadly combination of a trauma with a vegetative matter and also misuse of steroids, you can see this fungal keratitis. And in our area, we see them more seasonally, like in the reaping season, we see more number of ulcers. And it depends upon the area where you are practicing also. Suppose in South India, like Tamil Nadu, Andhra, our areas, in fungus again, fusarium is more common. Whereas in North and East, probably in Guwahati, aspergillus would be more common than fusarium. Candida can be there, but Candida is a rare infection. It's a fungal infection, but it is usually seen only in cases of immunocompromised individuals. In healthy individuals, you rarely see candidal infections. So let us now go into details of fungal keratitis. So fungal keratitis, if you see the three pictures here, all these three pictures, you can easily mistake them as a dendrite or a geographic ulcer. So always remember to differentiate between HSV keratitis dendrite and an early fungal keratitis. If you see here in this picture, it is almost like a dendrite. But how do you differentiate it from the dendrite of HSV? By simply staining it. If you stain it, you'll not be able to see any end bulbs or gutter in the branching here. So this early fungal keratitis, never mistake it as a viral epithelial keratitis. Same in the second picture. If you see the third picture here, suppose the patient has already used some drops and he has presented to you in this stage. So it is probably, this is actually a stage of healing stage of a fungal ulcer, but you can easily misdiagnose it as a geographic ulcer if you don't take the history properly. So early fungal keratitis mimics viral keratitis. Especially if you're from the Regional Institute of Ophthalmology, so you'll have access to microbiology department. So whenever in doubt, please do the scraping. So even if it is a viral keratitis, there is no harm in performing a scraping because you're going to reduce the viral load anyway. And if it is a fungus, by a simple KOH wet mount, you'll be able to appreciate the fungal hyphae, and then you will be able to differentiate and treat it appropriately. So next, let us go to the classical presentation of fungal keratitis. So usually these type of presentations you will see after 1 week or 10 days of infection, and these descriptions are already there in our textbooks. So these are like typical feathery margins, satellite lesions that are outside the main ulcer. So these are the typical descriptions of a fungal keratitis. The third picture where you are seeing here the pigmented lesion is again a fungal, but this type of carpet-like lesion, you see the causative organism is Demeticious fungi. How much ever drops you put in these cases, they will not respond until unless you lift that carpet with a fine-toothed forceps and peel off that entire epithelial plate. Only then the drug will penetrate below and the ulcer will start to heal. So whenever you see something like a plaque-like lesion, please try to debride it as far as possible and then put the patient on topical medication. Otherwise, this will just be like a plate on under which the drug will not penetrate, and the ulcer will start worsening further. And usually by looking only at the picture, if the lesions are more anterior stromal and they're more superficial, it is more likely to be caused by fusarium. And if the lesions are more deeper, if they have endoexudates and large hypopions, it is more likely because of Aspergillus organism. So deeper the organism, the more difficult it becomes to treat because of the poorer penetration of antifungals. So why do we clinically need to differentiate between fungus and Aspergillus? I'll let you know in the treatment part, because there is a variation in the treatment depending upon the species of the fungus you see. And as I've already told you, the third presentation can be like a superficial plaque, and this plaque is usually by Demeticious fungi. And in this, more than the topical treatment, the paramount importance is given to therapeutic debridement of that entire plaque, followed by topical medication. So now this is the advanced cases of fungal keratitis. So in this advanced case of fungal keratitis, you can see this subtotal ulcer, large hypopion, and central there is almost like an abscess. Maybe if you see this picture, you know that it's going to perforate in the next 2 or 3 days. And this picture here again is a case of advanced keratitis where the superior limbus is involved and the central part of cornea is also having a very large infiltrate with a hypopion in the anterior chamber. And this third picture is the end stage perforation where there is even the extrusion of the previously implanted PCIOL. So these are all the advanced cases of fungal keratitis. So fungal keratitis, how do you diagnose? So apart from this clinical thing, I think by just looking at the KOH wet mount, so you can just put a drop of 10% KOH and cover it with a cover slip and look under 10x magnification or 40x magnification, you'll be beautifully able to appreciate this fungal hyphae in the clinical microscope. And if you have access to gram stain and you do the gram stain, this is how the fungal filaments will look like in the gram stain. And this is the growth of fungus in potato dextrose agar. And these are the fungal filaments that you can appreciate in vivo confocal microscopy. So if you see here, what is the role of in vivo confocal microscopy? So any lesion that is scrapable, I think you will have good microbiological yield and you can get a proper diagnosis. But there would be certain lesions that are not scrapable. For example, lesions which are deeper or lesions which are in the tunnel. For example, you see in this case, the cornea is crystal clear, but this whole endoexudate you are seeing is extending from the inner lip of the post-cataract surgical tunnel. So in this case, when we did confocal microscopy, So you can see here the depth of scan we did is 834 microns. So that is, we are in the AC. That is why you see this black background and all these white reflective lesions are the fungal filaments. So this is how you can make use of in vivo confocal microscopy for cases where the lesions are not scrapable. However, the only problem with in vivo confocal microscopy, it is a very expensive tool and it is not readily available in most of the places. So in such cases, the alternative is you can do an AC tap, you can remove this material and then do the staining and also the cultures to know the organisms. But again, if you see at the lesion here, the way in which it has this feathery margins and cotton-like appearance, it is easy for us to guess that it could be a fungal ulcer. So going a step ahead, so if you have confocal microscopy and by just looking at the confocal images, would you be able to speciate or differentiate between fusarium and aspergillus? So if in fusarium, what happens is the hyphae are always branching at 90 degrees. So if you see here, the hyphae will branch at 90 degrees. So the same thing you can appreciate in vivo confocal microscopy. So there will be this long slender filaments and branching at 90 degrees. So if you see branching at 90 degrees, it is more likely that the causative organism is fusarium. In the same way, if you see branching at 45 degrees, so if you see here that dichotomous branching, so that is more common in aspergillus. So if it is a 90-degree branching, it is fusarium. And if it is a 45-degree branching and dichotomous branching from those branches, it is more likely to be aspergillus. So this is the difference. So if you see here, it is just perpendicular to the main hyphae. Here, there are more branching in a dichotomous fashion. So what is the treatment for fungal keratitis? Now that you have seen the clinical picture, you have seen the diagnostic modules, now let us see how to manage these cases of fungal keratitis. So if you see, as I have told you, if it is filamentous fungi, that is fusarium or aspergillus, the treatment of choice still remains to be natamycin 5%. That is the mainstay of therapy. And aspergillus, if it is aspergillus, you are confirmed, you can add voriconazole to it. But remember, the voriconazole was studied under 2 trials. That is the mycotic ulcer treatment trial 1, MUT1 and MUT2. In MUT1, they have used topical voriconazole. In MUT2, they have used oral voriconazole. So what happened in these trials was, the results was, they have asked you never to use voriconazole as a monotherapy. Even if it is an aspergillus, if it's a deep infection, never use voriconazole as a monotherapy. Always use it in combination with natamycin. Because if you use voriconazole as a monotherapy, in that group, they found that the perforation rate was higher. So that is the reason, always avoid voriconazole monotherapy. Use it in combination with natamycin. The advantage of this combination is both the drugs have a synergistic effect. When you use them in combination, the antifungal activity is even better. So that is the reason you have to use a combination of natamycin and voriconazole in deeper infections or infections that are more into the anterior chamber, like endoexudates and all. And for nighttime cover, we usually use itraconazole eye ointment. And for symptomatic treatment, like any other ulcer, you use atropine, analgesics, anti-glaucoma medication. And one more interesting thing is, we have done a randomized control trial to see the role of doxycycline in fungal keratitis. And we are going to shortly publish this study. In this randomized control trial, there was a significant impact of doxycycline in reducing the perforation rate in the fungal keratitis, not because of its antibiotic activity, but because of its anti-MMP, anti-metalloprotein activity, where it will lessen the corneal melting and thus help in the healing process. And therapeutic debridement, as I've already told you, it has to be done in all the cases. Ideally, you have to do therapeutic debridement every 48 to 72 hours so that the drug penetrate better and you're reducing the microbiological load. If it is candida, then the role of amphotericin B is there. Otherwise, amphotericin B we routinely don't use in fungal keratitis. Intrastromal or intracameral voriconazole, I'll discuss in the coming slide. And what we believe is, if you are giving the maximal medical therapy, that is natamycin voriconazole combination, 1 hourly treatment in waking hours, nighttime you have covered with itraconazole. You also have added systemic ketoconazole 200 mg BD. And despite this best treatment, if the ulcer does not heal in 2 weeks or so, then it is a time for you to take a call to go either for a surgical intervention or again see whether you are missing something or if there are compliance issues with the patient. And as far as cross-linking is concerned in fungal keratitis, I was lucky enough to be the part of the group that studied this during my fellowship days in Aravind. So we found out, and we were the first to do a randomized control trial to see the role of cross-linking in fungal keratitis. And it does not have any role, because what we have seen is when you use cross-linking in fungal keratitis cases, that particular study group had more perforation rate when compared to the normal group. Later, when we went back and saw the literature, what we found was probably because of cross-linking, we are making the cornea impermeable to the antifungal molecules that should reach this fungal organisms. And one area of interest where we are planning to do our research is the role of tacrolimus. It has already shown beneficial role in animal models. So probably tacrolimus can be used for its anti-inflammatory or immunomodulatory properties to reduce the immune damage that is done in fungal keratitis, whereas the antifungals can take care of the fungal infection. So usually if you see with this medical therapy in our institute, almost in 2 weeks, 75% of the cases heal well. So why do they heal well with this specific therapy? So there are reasons for it. So if you see, ulcers with specific therapy heal better when you compare with ulcers with empirical therapy, because when you give too many drugs, there can be compliance issues. So instead of the antifungal going in every 1 hour, it may probably go in only once in 2 or 3 hours in combination with antibiotics. And also with the antibiotics, you're going to kill the commensal bacteria that is there in the ocular Edenexa. And actually, these commensal bacteria, if you don't kill, are beneficial for your healing, and they actually act against the fungus. So these are the 2 main reasons why fungal ulcers heal well with specific therapy rather than empirical therapy, where you tend to add antibiotics onto these ulcers. So now let us see a small video of intrastromal injection. So if you see here, this is a case of post-keratoplasty. In the graft host junction, you can see a large abscess. So this is again caused by fungus. So here what I'm trying to do is I'm trying to first drain the abscess and then give an intrastromal injection. So if you see that mucus is very thick and I'm not able to drain it with that fine needle. So I have tried it several times. And finally what I have done was I removed the needle and directly with the tuberculin syringe, I aspirated the entire abscess. Once I aspirated the abscess, then with help of this 26 or 28 gauge needle, you can go into the stroma and then hydrate the stroma around the area of the ulcer with voriconazole. So the most important thing with intrastromal injections you have to remember is, whenever there is a frank abscess, There will be no role for intrastromal injections without draining it. And always be prepared to give repeated injections. Single injection may not suffice, and try to cover 360 degrees of the ulcer that you are seeing. And intrastromal injections are only like an adjuvant therapy to your topical therapy. You don't replace it with the topical. You continue your topical therapy, and as an adjuvant therapy, you can try these techniques in non-healing ulcers. So now let us see a case of eccentric graft. So if you see an eccentric graft, so this is like the ulcer is almost near perforating only in the superior area. So I limit my patch graft to that area only. So before I do that, if you see, I properly sweep the angles, and there you can see the exudates that are adherent to the iris. You have to gently remove those exudates before you close the anterior chamber with the tissue. So try to save as much as the normal cornea as possible. This is again one more case where you can see I have taken a eccentric graft. This is again a graft involving the superior limbus. This is again a graft where you can see almost it is going to perforate, and you limit the graft only to that area. So usually these kind of cases, first you can do a eccentric patch graft, and then you can follow it up with a central clear graft later. But if the sutures are not in pupillary area, the vision improves with RGP contact lens, and this kind of technique is more useful for tunnel infiltrates or infiltrates that are nearer to the limbus, where we can spare the other limbal area and the other normal corneal endothelium and save it for a future graft. So now let us see a typical total ulcer. So these kind of cases also we see once in a while, and it is a very challenging. So if you see almost the entire cornea is involved. So you can just see how the entire cornea has become like an abscess. So here you need not refine it. You can just do freehand dissection. And once you can see that button, it is entirely infected. Now with the help of gentle hydro delineation kind of a thing, and with fine forceps, you remove all those material in the anterior chamber, both above and below the iris, and then put the therapeutic graft. Here, if you see, I did not refine the graft because it's a large opening that I have done. So I have placed the donor tissue in toto with the scleral rim. And invariably, these cases will go into glaucoma and will require a shunt. But never lose hope. Always give a chance to the patient, even with worse cases like this. For example, this case, it survived, and later we implanted SF5OL, and patient is having decent vision in that eye, and he is on anti-glaucoma medication. And now that we have finished fungal keratitis, let us see pythium keratitis. If you see pythium, it is closely mimics fungal keratitis. So if you see, there are two lesions that differentiate pythium from other forms of fungal keratitis. So first one is this tentacular projections. If you see from the main ulcer, like tentacles, there will be projections outside from the main ulcers. And the second important feature is this peripheral gutter. Like PUK, you have this gutter in the periphery that is pathognomic of pythium. So when you're treating a fungal ulcer and you're not getting response, go back and try to look at these two things. One is the tentacular extensions and also a peripheral gutter-like lesion. If these two are there, probably we are looking at pythium. And also take a proper history. If he has a history of exposure to water, pond bathing, or if it is you are seeing it in a rainy season, it is more likely to be caused by pythium rather than fungus. So any fungal keratitis that is not responding to your treatment for a week or 10 days. Raise your suspicion for Pythium keratitis in such cases. Go back and look for these classical pictures and try to treat it accordingly. So if you see Pythium here, it doesn't have much of branching. It is more ribbon-like. It is more broader than the fungal filament. And these are the sporangia that you can see here, juice spores. And if you see here, there are the walls, the cell walls are thicker, and you don't see any septae in this ribbon-like hyphae. So there are no septae, the walls are thicker, and there will be some small vesicles that you can appreciate in this ribbon-like hyphae. So Pythium is an oomycete, it's not a fungus, but it closely mimics the fungal infections that we see. So Pythium management, we don't have any standard protocols, but the group from LVP by Dr. Bhupesh Bagga sir, they have described the use of topical linezolid. It works well. They use it on hourly basis. You can also add antifungals like itraconazole, voriconazole, or econazole, and also topical azithromycin ointment also works well. Oral azithromycin 500 mg OD, you give it on day 1, followed by 250 mg for the next 6 days. And remember that Pythium is a very, very challenging disease. It can be very invasive. You also have data from the All India Institute where it has also extended into the brain and it has caused death. So it's a very invasive disease. So when you have a confirmed diagnosis of Pythium, try to treat it with the following antimicrobials. If it doesn't work, it is better to go in for an early TPK. Sometimes when the infection is uncontrollable, you may even require evisceration or enucleation. However, we have seen less number of these cases, so we don't have much of data. As we get more and more data, probably in the future, we'll have more standard protocols for this dreaded infection. So now let us go to bacterial keratitis. So bacterial keratitis, I have told you, again can be caused by gram-positive and gram-negative. So if it is gram-positive, it is more well-defined and superficial like you see in the above pictures. However large it may be, it will always remain well-defined, and it is usually caused by a gram-positive organism. But if you see here, this is gram-negative. So what is the hallmark of a gram-negative infection, especially Pseudomonas? So what happens is these gram-negative infections worsen within a matter of hours or days. The clinical picture you see today, it can be like this, and it can turn like this within just 24 hours. So whenever you are seeing a case that has rapid deterioration, rapid worsening, always suspect gram-negative bacterial infection, which can be Pseudomonas. So in the Pseudomonas, the inflammatory component is more when you compare to the infectious component. And because of this inflammatory component, there is advanced melting, corneal perforation, and sudden deterioration of the condition. So these are the microbiological pictures. If you see here, gram-positive cocci in pairs, usually it can be because of streptococcus. And these are gram-positive bacilli. This is atypical mycobacteria. And this again, what you have here is gram-negative bacilli is Pseudomonas, and GPC in groups is Staph aureus. So the most difficult thing to identify in bacteria is the gram-negative organism or gram-negative bacilli. Because if you see in the other 3 pictures, all the gram-positive organisms stand out from the background, whereas the gram-negative organisms are lost in the background. Until unless you look for them specifically in the background, you may not be able to pick up these gram-negative organisms. So that is the reason it is difficult to diagnose. You have to look more carefully to rule out gram-negative organisms. And the treatments that we see here, for gram-positive, we either give moxifloxacin or gatifloxacin. Along with it, we give fortified cefazolin. And nowadays, you also have the levofloxacin that is available. We give oral antibiotics in deeper ulcers. And nighttime, we cover with antibiotic eye ointment along with symptomatic therapy. Whereas in gram-negative, along with moxi and gati, the mainstay of therapy is fortified tobramycin or gentamicin. Whatever gentamicin and tobramycin injections that are readily available, if you just add those injections into the tobramycin or gentamicin drops that you have, they become fortified drops and they work better on gram-negative organism. So is there a role of steroids in bacterial keratitis? That is what this CUT study has studied from the Arvind group. They have almost studied 500 cases where they have seen that in for bacterial keratitis, previously everybody were apprehensive to start steroids in ulcers. But what they have found out is ulcers per se may not have a beneficial effect, but at the same time, they do not cause any problems also. But there are particular conditions in which where you can try using steroids, but this has to be done only after 100% microbiological confirmation and you have a backup to do a graft, probably in an institute like scenario. So there is a subset of Pseudomonas that rapidly progresses that I have showed you in the previous picture. So in that places, probably the steroids, topical steroids have a role, because what they have seen in that particular subgroup where Pseudomonas was rapidly deteriorating, steroids, when you start, the inflammation comes down, the final outcomes of scarring and visual improvement are also significant when you compare to the group in which they did not use steroids. Cross-linking also has a beneficial role in bacterial keratitis, but practically we did not do cross-linking in most of the cases because most of the gram-positives heal very well with antimicrobials alone. Gram-negative, when you intervene at an appropriate time, probably you can use, once it is confirmed, maybe you can start steroids. And then, for example, this is the case of a contact lens user who has presented to us with just PLPR. So if you can see here, just 2 weeks follow-up, patient improved dramatically. And by 1 month follow-up, just using gram-negative organisms like tobramycin and gentamicin along with steroids, we could get these results. So now let us see another kind of bacteria, that is atypical microbacteria. Atypical microbacteria again is a very rare infection, but this infection, whenever you see, it is very difficult to diagnose. Just like gram-negative bacilli, it is a both microbiologically and clinically, it is a very difficult disease to diagnose. But the typical appearance you see here is nothing but the cracked windshield appearance. So that appearance you see in the stroma of a cracked windshield, you should have high suspicion for atypical microbacteria. And don't be misled by this pseudo dendritic pattern that you see in the center. So cracked windshield appearance, and especially if you are seeing an infection post refractive surgery, specifically LASIK surgery, 50% of the time it is more likely to be caused by an atypical microbacteria rather than other organisms. So it mimics both fungal and viral keratitis. It is very difficult to diagnose. The reason why it is difficult to diagnose is, if you see in this picture here of gram-positive, because of large amounts of lipid in the cell walls, there is something called as negative staining. These atypical microbacteria in this center do not take up the stain. But if you see here that white slender things that did not take up the stain, with special stains like Gill-Nielsen, then you will be able to appreciate and delineate the cell walls filled with lipids. The lipids in the cell walls again are a reason for difficulty in the treatment also. The drug will not penetrate the cell walls and act on the organism that is there. So atypical microbacteria, always a difficult to think because of this negative staining. And for clinical thing, if you have a cracked windshield appearance, pseudodendritic appearance, and if it is post-refractive surgery, especially LASIK, you should have high suspicion towards this organism. And the treatment for this is amikacin. It can be 2% or 4% eye drops, followed by gatifloxin higher strength or moxifloxin eye drops. Again, azithromycin, you can use 500 mg on day 1, followed by 250 mg from 2nd day to 5th day. So at least give it 1 month. This is a very, as I told you, the lipid layer is more. It will take longer time to heal. At least give it 1 month to start resolving. If it still doesn't resolve, then think about surgical intervention. If it is a post-LASIK one, don't hesitate to amputate the flap also and go in for a therapeutic graft. It doesn't heal. And finally, in the bacteria, let us see the filamentous bacteria, that is Nocardia keratitis. So Nocardia keratitis, if you see, this has this typical wreath-shaped appearance. So this wreath-shaped appearance is classical finding of Nocardia keratitis. So if you see Acanthamoeba, this is in this picture, it is more broader and it is a continuous ring. And here you will also have perineuritis, whereas in Nocardia, it is wreath-shaped. It is not a continuous ring, and it is less denser when you compare to Acanthamoeba. Nocardia can also present in the form of this tunnel infiltrates that you see here, and usually these tunnel infiltrates can lead to endophthalmitis. So if you see, these are the filamentous bacteria. They are more slender when you compare to fungal filaments. See, these are the fungal filaments which are more broader, whereas this filamentous bacteria, it is just like a small chains that go continuously, and they are dot-like filaments. That is how you differentiate microbiologically. And this is the pythium, which is more ribbon-like, and this is the fungus, and this is Nocardia. So don't confuse between these 3 filaments. So the management of Nocardia is again similar to atypical microbacteria. Is amikacin 2% or 4% that you have to reconstitute and give on an hourly basis. And 4th generation fluoroquinolone like Gatti or Moxi. Systemically, you can also give amikacin injection if they are more nearer to the limber or tunnel infiltrate. Orally, you can give sulfametazole and trimethoprim combination, and that works well in these cases. So now let us go to Acanthamoeba keratitis. If you see Acanthamoeba keratitis, this is this typical initial thing you see is this classical perineuritis. So there will be intense pain. So whenever the patient is having intense pain, always suspect Acanthamoeba keratitis. Then it will continue to form this typical corneal ring that you see, and it will worsen to become the picture in the 3rd frame. So these are the double-walled Acanthamoeba cysts that you can appreciate in KOH wet mount, and these are the Acanthamoeba cysts that you can see in vivo confocal microscopy. The treatment of choice for Acanthamoeba is PHMB or chlorhexidine. PHMB or chlorhexidine will be commercially available like a swimming pool disinfectant. So what you need here is you should have a micropipette and then microtitrate it into this concentration so that you can use it for ophthalmic purposes. Pain management is the most important in Acanthamoeba keratitis. Your regular analgesics may not work here. So either you can give amitriptyline 25 mg BD or TID depending upon the pain. You can also give gabapentin in these cases where pain is not controlled by regular analgesics. So after 2 weeks of antimicrobials, you can start steroids in the case of Acanthamoeba, especially when you see vascularization, melting, scleritis, lid edema, and patient is very symptomatic. These are the signs in which you can start steroids because these are all the signs of inflammation. So apart from taking care of the antimicrobial activity, you also have to address the inflammatory response. In these cases, there are good reports of doing a DALC or therapeutic graft, mainly as this is a very chronic disease. It'll take time of more than 1 to 2 months. Surface toxicity can mask this disease. So always try to know that there can be some amount of signs of surface toxicity in these organisms. So finally, let us see microsporidial keratitis. So microsporidial keratitis are these fine dots that you see here. There are more like stuck-on appearance that is there on the epithelium. When you compare it with viral SPKs, viral SPKs are more pinpoint and there are more central and they are on the surface of the epithelium. They do not rise over it. But here, if you see, there are more stuck-on appearance, and they are raised, and they are having this crumpled appearance. And this kind of stromal form of microbial keratitis you see rarely, but you see in immunocompromised individuals. And the treatment of choice, this is the microsporidia that you see in gram stain and on confocal microscopy and immunofluorescent staining. So manual debridement with a moist cotton tip. See, this is picture taken by one of our fellows. If you see this typical coarse stuck-on appearance, just you moisten the tip cornea of the corneal bud, cotton bud, and try to debride everything, it will just become clear like this. So with manual debridement itself, most of the organism load is gone. Then you can, as this organism is more closer to the fungal species, we prefer to use fluconazole or voriconazole eye drops in these cases for 2 weeks. Night cover, you can give itraconazole or gatifloxacin ointment. If the stromal keratitis is very difficult to treat, you have to take the case for TPK, and stromal disease will have a poorer prognosis. So let us finish it off with HSV epithelial keratitis. So if you see HSV epithelial keratitis, this is the primary lesion, how you see it. So this epithelial lesion is an active replicating virus in which it is in the infectious phase, where you can see this typical double staining, end bulbs, and all these things. So these coalesce to form a large geographic ulcer. So how do you differentiate this with other pseudo dendrites? As I've told you, fungal keratitis also early, it can mimic this. Atypical microbacteria also can mimic this. Coming to varicella zoster, the lesion is more epithelial and there is no central ulcer or terminal bulb. So if this picture is varicella zoster dendrite. So there is a condition called as zoster sign herpetae, where there need not be any skin involvement, but herpes zoster affects only the cornea or the eye, in which you can see this epithelial dendrite, and this you can easily differentiate from the HSV with the lack of end bulbs and central ulceration. And simple debridement also works in these cases. And also suspect, whenever you're putting the patients on antivirals and they're not responding, have a high suspicion that it could be a pseudodendrite. So HSV keratitis, the treatment of choice, if you treat it or not, also it sometimes can resolve spontaneously, but if you treat it well, it will have a better prognosis. Like topical, we prefer to use ganciclovir gel ointment 5 times a day for 2 weeks. Don't use these ointments for more than 2 weeks. If you use it more than 2 weeks, it can have a surface toxicity. And oral acyclovir, you can use it 400 mg BD and along with topical nighttime cover. So never use steroids in HSV epithelial keratitis. Now let us see the HSV stromal keratitis. So stromal again is in 2 forms. One is the necrotizing form and non-necrotizing form. In necrotizing form, there is overlying defect. Here both viral and immune-mediated destruction is going on. Here there is definitely role for antivirals along with steroids. Whereas in non-necrotizing, you need not use antivirals. It's more of an immune response. So here steroids are the mainstay of therapy. In HSV endothelitis, again can be in 2 forms, disciform, diffuse, or linear. Here again, you have the role of steroids with oral antivirals. Always remember that in HSV endothelitis, there can also be IOP rise because of trabeculitis, and you need to use anti-glaucoma medication. So in HSV, B-wise, layer-wise. So if it's epithelial disease, it is dendritic or geographic keratitis, never use steroids. Only use antivirals like ganciclovir or acyclovir 5 times a day for 2 weeks. If it is stromal with ulceration, give topical steroid with oral antiviral prophylaxis like acyclovir 400 mg BD. If it is with ulceration, give therapeutic doses, that is 400 mg 5 times a day with topical steroid. Endothelial keratitis, oral in therapeutic dose with topical steroids. So now let us see what are the oral acyclovir is the drug of choice that we give. So the prophylactic dose, as I've told you, is 400 mg twice a day, and the treatment dose is 400 mg 5 times a day. Okay. So when does this HSV recur or reactivate? It usually recurs because of stress, exposure to sun, fever, trauma, menstruation, certain medications, and even after cross-linking. So these are all the triggers for HSV. So important and relevant, how do you differentiate between HSV and HZV? There will be obvious skin lesions, and there will be HZV is more common in immunocompromised individuals and diabetics. And in epithelial disease, it's easy to differentiate. Stromal and endothelial disease, it's difficult, but however, the treatment remains same. So whenever in doubt, always give the treatment of HZV that is more. It's better to err on the HZV side rather than the HSV side. So for HZV, the therapeutic dosage instead of 400, this is 800 mg as acyclovir 5 times a day for 1 month. So this is polymicrobial, where you see both fungal and bacterial infection in the same plate. So to sum it up, if it is fungus, fusarium, feathery margins, anterior stromal, branching at 90, treatment is NATA. If it is aspergillus, deeper lesions with endoexudates, dichotomous branching at 45, add voriconazole. If it is dematicious fungi with pigment, it is superficial carpet-like pigmented growth, do therapeutic debridement followed by antifungal. If it is candida, it's deeper infection, give amphotericin B. If it's gram-positive, cefazolin plus fluoroquinolone. Gram-negative, there will be rapid course and corneal melting, tobramycin and gentamicin along with the role of steroids. Atypical macrobacteria, amikacin and oral azithromycin. Acanthamoeba, PHMB and chlorhexidine with proper pain management. Nocardia, amikacin with trimethoprim and sulfametazole. Microsporidial, therapeutic debridement and fluconazole. So this is the take-home message. So if you are carefully looking at this slit lamp, 60% of the time you can diagnose it by clinical examination and history. Try empirical therapy only for 5 days. Don't try to prolong empirical therapy beyond this. And always take expert opinion in cases of central ulcers or in an ulcer that is more than 2 millimeters, or if the patient is a child, or if the patient is a one-eyed patient, don't delay the treatment of microbial keratitis. Most of the private practitioners outside, they give all this medication, but the problem is they don't do the proper dosing. They only give it 4 or 5 times a day. No, we have to give it 1 hourly. If possible, give a loading dose. That is for the first 30 minutes or 1 hour. When the patient is in the OPD itself, try to put a drop every 5 or 10 minutes so that the drug will reach the dose in which it will start the activity, and then ask the patient to continue to use it 1 hourly. If you ask the patient to buy and use it later, there will be almost 3 or 4 hours gap before he puts the first drop. Instead of that, put the first drop in the clinic and put the loading dose. Maximum medical therapy, you try for all these interventions for 2 to 3 weeks. If it doesn't respond, go in for an early surgical intervention. Invest in a good clinical microscope. You will be more confident in treating these conditions. So thank you for your kind attention. I thank my teachers, Dr. MS sir and Prajna sir, for sharing their experience and giving us this wisdom from their years of experience. And I also thank my team members from Srikiran Institute of Ophthalmology, the cornea team. So this is my email ID. If you have any interesting cases of microbial keratitis, if you can send in the clinical pictures, we and our team members will have a look at it and get back to you with our collective wisdom. Thank you again for the wonderful opportunity, and thank you for the patient hearing on this Saturday evening.